Good afternoon, everybody. Thank you for joining this cadaver lab session discussion of the use of illuminous in the pelvis. We're going to start with some slides to go over the general principles of what illuminous is and how this is used. Before discussing some cases, then we will evaluate the surgical technique and see some of the steps and the principles to do this in patients with metastatic disease. And after discussing the cases, we will have some time to have discussion and questions. So illuminous has been in use since 2010. It's basically an intramedullary device that is photodynamic. So it's a very particular implant that is really not comparable to other technologies available out there, in which you're able to insert a balloon with a polymer that follows the anatomy of the patient. And this facilitates the insertion, especially in curved bones, in my opinion. The first studies were in the use of the proximal humerus and in the humerus in the upper extremity. And this proved to be a very good technique to decrease the amount of pain in patients. Subsequently, it was approved for the use in other parts of the upper extremity, then for use in the pelvis, and then for use in the lower extremity with the augmentation of a hardware. There are different uses. You probably have seen cadaver labs that have been presented to you before, in which the balloon has been used for the treatment of distal radius fractures, especially in patients with osteoporotic bone. This facilitates surgical treatment through a very small incision and using the balloon to restore the articular height. As I described before, it has been used in the proximal humerus for metastatic disease and impending pathologic fractures or minimally displaced pathologic fractures. In the trauma world, it has been used especially in osteoporotic, periprosthetic, or periarticular fractures of the distal femur, in which the medial and lateral column of the, or supports of the femur have been recreated with the balloon before using a plate with non-locking and locking screw construct to reduce this type of fractures in which the bone quality is not very good. Next slide, please. So the way that the implant works consists in making an incision in approaching the bone and making a pathway that follows the direction of the area of anatomic interest that we have. After using depending on the location, a guide wire of different thickness, you can measure the length of the balloon that we're going to use. Depending on the size of the bone that we're working on, there is going to be a process of subsequent rimming to make the path for the balloon. Then the balloon gets inserted. They come in different lengths. They come in different widths, and they also come in different shapes that might be conical, having parts that are thicker in distal part and narrower in the most distal part, or vice versa. After you pick up your balloon that fits better the anatomy for the problem that you're trying to address, you insert the balloon, and under fluoroscopy, you can expand the balloon by inserting the polymer that ultimately is going to cure and harden. This is done by connecting the balloon to a source of white light that causes the process of curing, and then what we describe as the photodynamic stabilization. After the balloon hardens, there is a series of devices that are used to cut the connections to the balloon. There is a method in which you confirm how the balloon has cured appropriately, which we will go over that while we're doing the balloons in the pelvis. So we're going to move now to the pelvis. And before we go to some of the cases, I just want to emphasize some of the principles of how we think about the pelvic bone. So one of the principles is that the pelvis for us is a pelvic ring, and we can use balloons that come from the anterior part through the superior pubic bone into the supraacetabular area to help to close that pelvic ring in insufficiency fractures or metastatic lesions that are affecting that pubic ramus or the anterior column of the acetabulum. Next slide, please. Another important concept is about the stability surrounding the acetabulum, which is probably the most relevant area in terms of biomechanics of the acetabulum and the pelvis. As most of you know, the pelvis contains the acetabulum. This is a socket, and that socket is supported by two columns. I have a plastic design here that shows the trajectory of that posterior column and that anterior column that you see also in the presentation with the bar colors. What I like to reconstruct is the bar that is in the red color, which is a sciatic corridor bar that basically comes from the back of the pelvis to the posterior inferior iliac spine, across all the way to the front to the most anterior part of the supraacetabular area. The second area that I like to support is the posterior column, and that goes through a balloon that comes from the ischium in a retrograde manner all the way up as high as it can be in the posterior column in the junction to the iliac element. That forms a T in which you can see the shadow here in the plastic model, and you see as well in the slide. That T supports the acetabulum, and that allows to restore the weight-bearing surface of the acetabulum, which is what resolves the pain that patients have when they have lesions in these areas and have impending pathologic fractures. Also, these are the areas of bone that we want to reinforce if we're going to use constructs like total hip replacements, for which IlluminOss is also an alternative that I think is very useful in contained or non-contained defects, as well as in patients with osteoporotic bone. The last part I mentioned was from the front. That one is done with the patient in the supine position, and the trajectory is marked through a superior pubic rami going to the supraacetabular area. You can also have the possibility to stabilize the posterior part of the pelvic ring. That would be the sacrum in the iliac bone, and that applies also for patients with insufficiency fractures of the sacrum. Next slide, please. So these are some slides that show the trajectory in more detail that I was showing you with the pelvic model. Next slide. And what I like of this device is the alternatives that we have for what has been traditionally our standard of care, such as large cannulated screws with cementation, is that this device, because it follows the anatomy of the patient, it follows also the anatomy of the defect. So that allows to create a bar that is going to get thicker in the area where the bone is at the weakest point. The advantage is that that wider diameter is in the area where the tumor is, and is in full continuity with the device that you are using to rebar the entirety of the pelvis in that T concept that I was explaining. In addition, the space that you have for the balloons allows you usually to put balloons that measure at least 13, 14 millimeters in diameter, and that compared to the largest screws is probably twice the size. And as you know, any minimal change that you have in the radius of a cylindrical structure has significant impact in terms of the biomechanics and strength of that device. So the fact that we can use a longer bar, thicker in diameter, radiolucent, and that it expands at the points where there is the weakest point that you are trying to address, makes the device very appealing for these patients with metastatic disease. As we will see, the incisions are small, and with the use of technology such as navigation or fluoroscopy, you can insert these balloons in a relatively rapid fashion compared to other surgical techniques. Next slide. So before we get to, well, this is an example where I'm going just to show some of that example of the balloon expanding. This is a patient with multiple myeloma that has a lesion in the anterior column of the pelvis. You see the MRI showing those images. Next slide. Then you can see a coronal view with a T2 sequence in which you see in a high signal on the left hip in the anterior column, the increased signal reflecting the lesion. Next slide. And then you see here a CT scan in the coronal view and in the axial view that shows the lesion with the balloon inside. So you see how the balloon expands and fills the entirety of the defect, explaining that concept of the device getting wider in the areas where more stabilization or more strength is needed. Next slide. This is the final X-ray, and you see there the balloon going from the medial part of the superior pubic rami all the way up to the suprascapular area, getting wider in the area where the previous lesion was located. Next slide. Okay. So why this technology is different? The incisions are small, as I mentioned. The surgical procedure time is relatively short compared to other technologies. You decrease in a significant manner the amount of blood loss. It is radiolucent, so it allows for an easier follow-up of patients, especially oncologic patients, in which you want to assess response to radiation or systemic therapy. It supports the pelvis in a longer distance compared to other techniques. And you have the ability to add hardware or other materials into the material, such as plates, screws, which with the implant you can get better grip than the patients affected or osteoporotic bone in patients that do not have metastatic disease. Next slide. So before we move to the cases, we're going to review the surgical technique. You can do this in the supine position for the balloon that goes to the anterior column. And you can also do the balloon for the posterior column with the patient in the supine position if you have an assistant that helps you to flex the hip and the leg while you are palpating the ischium to make your incision. The other way to do it is in the prone position, and that's my preferred approach, as I think the visualization and use of the arm in the fluoroscopy is the most convenient for the surgeon. And that allows you to do the two balloons, the posterior column and the sciatic corridor in a simpler manner, in addition to have access to the sacrum if you need to add some stabilization in that area. Sometimes these patients with metastatic disease have also disease in the femur, and you need to do intramedullary nail, for example. So this can be also performed in the lateral decubitus, as you will do also if you need to do a total hip on the patient. For positioning of the patient in that setting, I prefer to use beam back, as that allows you to come lower in terms of the preparation of the patient. You can also use a hip grip, but you just need to be sure that you use the shorter cushions for the posterior part in the sacrum, and be sure that you put that support a little bit further towards the head of the patient that you would usually do for other procedures. For this setting, in this cadaver lab session, we're going to have the patient in the prone position. So the first thing to do, and I just want to be sure that you can see the cadaver, is to palpate the sacrum, the ischium, excuse me. You make a small longitudinal incision in that area. Most people get nervous about the sciatic nerve in this location. The sciatic nerve usually in this location goes more lateral towards the ischium. I'm trying to mark it on that line. So you just need to feel the ischium and make your incision. You can either start with a guide wire or you can use a drill. Usually the drill that I use is a 3.2 drill that I use in a wire driver. The way that I set up that drill is leaving a distance of 9 centimeters. As I mentioned before, most of this I do with the arm, and the tracker for the arm I place in the most superior part of the iliac crest, just lateral to the posterior superior iliac crest. We're going to shoot an X-ray, and you're going to see there that we just marked with our wire the trajectory for that posterior column initial value. As you can see, the trajectory of the wire goes or should cut ideally part of the femoral head, and that's a marker that the position is appropriate. Sometimes people feel safe trying to start this more medially, and you actually end up going to medial and losing bone that you can get more lateral. Position, the next shot that you want to do will be iliac oblique shot on the floor. So please see over and pull back towards you. X-ray. So that's X-ray then. So that shot shows you a lateral view of the acetabulum. It shows you the space in the joint and shows you that you are in the appropriate position and outside on the joint in this case. Then you want an orthogonal view of this that we just took. So you want to go to an obturator oblique view and then push in a little bit more. Then bring your machine down if you can. X-ray again. And then in this view, we peel back a little bit more and then come lower. You see that you are in between your outer and inner table in the iliac bone. So with this, you know that you are in the appropriate position. Let's go back to the iliac oblique view. Sometimes if you want to improve the visualization of the wire, you can combine this iliac and oblique Judet views with inlet and outlet views that will give you a better visualization of the column. I think those combined views are better to visualize the sciatic correlate. So here, after having using your drill or your guide wire, what you're going to do is to advance a node. I have this wire here already in place, so I'm not going to take it down to do the drilling just to save some time. But basically what you want to is to advance your straight hole X-ray, and you just confirm that you are in appropriate position in the bone. Picturing or imagine that this wire is your drill, you take it out, and what you do is to take your 2.0 voltage guide wire, and you're going to advance that into the position X-ray there. Do you have a T-handle? Do you have a T-handle? So once you find your trajectory, X-ray there, X-ray there. So you advance your wire where it needs to be, and then over that wire, you use a series of reamers after you measure the length of your balloon. So there are different ways of measuring that balloon. You can use another 3.2 millimeter guide wire, and what you do with that is put it over, get where you feel the bone, and with a ruler, you can measure the extra length that you have for the length of your balloon. you can also use the ruler or device that they have to measure the balloons, and you can get your length with that. My preferred way is to do it with the second 3.2, excuse me, with the second 2.0 guide wire. X-ray there. So you start your reaming and you do it sequentially, starting with a 6.0 millimeter flexible reamer, and you advance that by half, so you go 6 millimeters, 6.5, 7, 7.5, and 8. To pass the sheets that you need to do, or to advance to put the balloons, you need to ream at least to size 7 millimeters, and that should be sufficient. I like to make the corridor as wide as I can in order to get the thickest balloon that I can. So let's see back over a little bit more. Excuse me, over like as much as you can there, and then maybe pull back towards you a little bit and drop the machine a little bit. It's right there. Okay. There is a device that you can use to help to give rigidity to your flexible reamer. It allows you to pinch it in between and make it at the end a little bit more rigid, and then you advance. So after you finish that process of the reaming, and as I mentioned, you just do it by different steps, you get to put your sheath. The sheath comes with a flex, and that advances over the wire. Looks right there. Then you can see the shadow of the sheath, and what you do is to turn 90 degrees the trocar, and with the trocar, your bolt tip guide wire comes out. X-ray again. So you see there the shadow of your sheath, and again, you can confirm the position with your orthogonal view, which in this case will be an obturator oblique. And for purposes, we measured this balloon before, so this is going to be a 22 by 18 by 90 millimeters balloon. I like to use the one that has the reverse conic way, because the wider part is distal, and that fills up the supraacetabular area. So do you have the balloon? Whatever size you have. So the way that this, can you see this one's here? So this is the device. So you have here the injection with the polymer. You have a two-way key here that allows you to inject and allows you to secure to avoid the back out of the polymer. You have the connection of the light source. So when you're done, you unscrew this part, and if the balloon is appropriately cured, this light source should pull out with no difficulty. This yellow part is the connector to the light source. The device comes with this straw that, as I mentioned before, the entirety of the sheath until both ends come out. Stretch, thank you. X-ray there. So you can see there the spiral that shows the shadow of the balloon. It is important that you keep things as aligned as you can. You want to avoid kinking or folding of the light source, and you want to avoid also areas of you know, like getting it dirty with blood and things like that. So I'm going to start inflating. You go slow and take your time. You want to avoid any balls that you could see. X-ray there. And you see how the balloon is expanding there and following the size. Okay. So then when you finish, you will feel a resistance on that. And then you confirm again with orthogonal X-rays the position of the balloon before curing, and then you can start the process of curing. So to save some time, we're just going to connect this to the light source, and then we'll move to the second balloon. So in the operating room, this lab, just because to show you things better, we have regular light, but you want to have the room with dim lights to avoid the curing of the polymer. Then you come to an AP of the pelvis. And then if we could do that inlet view, yeah, raise it and make an inlet view. Then you see the light source there doing the curing of the balloon. So the length of time depends on the size of the balloon and the amount of polymer that got injected. Can you go more proximal? As you can. Can you go like somewhere in here? So for the second balloon for the T, we made the incision already. You try to get kind of like the mid portion of the posterior iliac spine. And if you're using fluoroscopy, you basically want inlet view. You can go back a little. Let's try that. It's right there. So you can see basically the posterior aspect of the iliac posterior inferior spine. And then you mark the trajectory of your balloon and you advance. You can come to the AP again. Then to see your sciatic corridor, the best view is to get an iliac oblique view. So come more distal. And then see over. And then pull back north a little bit. Let's see where you are there. X-ray there. Can you go a little bit more north? So you basically advance the wire again. You see it there above the corridor, and you see the T that I was mentioning before. We did some measurements before and pre-drilled this area, but the same process of sequential rimming will take place. And then we're going to do the same process in which we're going to advance the sheet over the balloon. So you do the same 90-degree turn. Just let this way. Sorry. Then you take it out. Then you have your next balloon, which is the same business. So 1820 by 90, that's what we measured before. And then same process of splitting your sheet. Advancing the balloon. And then we're going to inflate the balloon. Let's get an X-ray there. Then you see the balloon expanding there above the sciatic corridor, forming that tip. So basically inject as much as you can. in that you know that we're outside the joint. And basically we stop and we connect again the balloon to the light source. And we await for the cure. Once the balloon's cured, then we can go over the process of cutting them. And in the meantime, we're going to review some cases, and then we will set up for the balloon that goes in the second. So let's go back to the presentation. If you want, you can pull back with this one. So this is the imaging showing kind of like the steps of a patient in which we did the same type of teeth reconstruction. I think an important thing for this balloon that comes in the sciatic corridor is that you can change the angle a little bit depending on the area that you want to supplement or support the most. If you want to go to the most lateral part of the acetabulum, the best way to do that is to aim in an additional 30 degrees and starting lower in the posterior inferior iliac spine. If you want to support more of the supraacetabular area, it's better to start a little bit more superior and then aim a little bit more medial. The use of the drill or the wire is a surgeon's preference. I like the drill because it allows you, especially with navigation, to mark a clear trajectory. I prefer to use the navigation than the fluoroscopy alone, because in many cases the bone of these patients is weak and there is a lesion in which maybe you're not going to have feedback when you're advancing your wires, and you can avoid that marking your trajectory with navigation. You see here some of the projections and slides that show those views that I mentioned above, mainly the iliac oblique and obturator. Next slide. Just going to get where we were to case number 1. So, as I was mentioning, you can do this with fluoroscopy or only with navigation or both. I like to use the combination of both. As you can see, the balloon deployed with the fluoroscopy. In these images, this is another case in which we were supporting the supraacetabular area and also performing this posterior column. You see in the inferior left side the tracker of the navigation, the shadow of that. Next slide. Then you see some of the other shots that are the obturator views. Next slide. And this basically highlights the position of the balloons, showing that concept of the T that I described before. Next slide. Next slide. So this is a CT scan first patient that has a periacetabular lesion. So as you can see in the axial cuts, the patient has involvement of the posterior column. There are some balloons following that trajectory, and there is also some involvement of the supraacetabular area that we supported also with the balloon. Those are the sagittal views. Next slide. So this second case is a patient that had metastatic hepatocellular carcinoma. He had a lesion in the superior left acetabulum, and he wasn't progressing to or responding to his systemic therapy. It was due to change his therapy, but he was very symptomatic in terms of impossibility to bear weight in his left hip. Next slide. You see some of the other views where you see the defect in the supraacetabular area more towards the lateral side. Next slide. This is the CT scan of the patient. You're going to see the coronal views in the upper left, the sagittal views on the upper right, and the axials at the bottom. And then you're going to see that lesion that is a non-contained defect in the supraspinatus area. So one of the pros that I see on these photodynamic nails is that you can use them in non-contained defects, something that you cannot do with cement injections. Next slide. Here you can see the balloon inserted. We put basically the suprascapular balloon. Next slide. And then this is the patient 6 weeks after surgery. He was weight bearing as tolerated immediately after surgery. At this point, he had started already his chemotherapy. This patient has a 9-month follow-up, and he's doing very well functioning. Next slide. This is the X-ray of the patient in 9 months post-op. So you see that same principle of the supracetabular area reinforcement as well as posterior top. Next slide. So this is a patient with multiple myeloma that had multiple lesions in the paracetabular areas in the left and in the right hip. He also was having mechanical pain with axial loading. And in his case, we decided to reinforce both periacetabullar areas with both the sciatic corridor balloon as well as the posterior column. Next slide. These are some other projections that show the defects that the patient had. Next slide. And then you can see some of the projections with the balloons, where the balloons are going to be. Next slide. There's some intraoperative images here showing the balloons supporting the area in the supracetabular area in the posterior column. Next slide. This is more showing the same. Next slide. You see the balloons deployed there. This is a combination of the iliac oblique views and obturator oblique views. When in one hip you're doing the obturator view, the other hip has the oblique view and vice versa. Next slide. Next. And then there are some images here with the CT scan showing the balloons in position. So that's a sagittal view, coronals, and sagittals. Next slide. This patient had metastatic breast cancer. She had a supracetabular lesion and involvement of the anterior column. We put a balloon in the anterior column, and we did a total hip on top of that. You can see the screws going also through the lesion and providing support for that. For this situation, I did the balloon first in the supine position. To get this balloon in the lateral position is very difficult because you have to go very superior and posterior in relation to the scapula to get the angle, to get the trajectory. And most of the time, you have some branches of the superior gluteal artery that may get on their way and cause some unnecessary bleeding during surgery. Next slide. You see a postoperative view there. And the patient also has been weight bearing and doing very well. So now we're going to turn back to the sacrum and how you position these balloons. Basically, what we're going to do with this is to get inlet and an outlet view to determine the height of your balloon. This incision is usually more it is, especially in obese patients. Can you go a little bit north and take an AP? Pelvis, and then bring your machine down. And then go north. Okay, fix right there. So you have your inlet view, and that's what is going to localize your balloon in terms of anterior to posterior location. Can you tilt back this way? X-ray there. Can you go further up? So actually go the other way. So bring this here on this way. So we're going to get what will be an inlet view. Then go north. You need to be somewhere in here. I need you to bring down this, like bring this down. Okay, try that. X-ray there. So then you see there the image is upside down, but you see at the bottom your lumbar is fine. Maybe you can spin that for us, like make it. And then you see the foramina of S1. Perfect. If you could do a little bit more. That's great. Thank you. So then you can see that your sheath is above the foramina of S1. So with this, we're getting basically a stabilization through both iliac wings as well as the second. The same process of advancing the wire takes place. I'm going to try to make some sort of ninja move here. X-ray there. So X-ray. X-ray there. Okay. So you advance to the other area. Same principle of measuring the length of your balloon. So this is the other 2.0 wire. I'm feeling here my iliac bone, and basically what I will do is take a sheet and with a paper ruler measure this distance. For these purposes, we're going to use, what balloon do you have for the back? This one, we'll use this size. And then basically you do the same rimming process that we mentioned before. We have a flexible rimmer just to open this one. Yeah. You have a T-handle, I have it here. Just going to advance this. A little more. X-ray there. Okay. And you can feel the resistance there on the other end. And then you basically use your rimmer. You go by sequential sizes. I'm just going to pass here very quick the size 8 X-ray there, just to go across. There is similar to what you do with intramedullary nails. There is a device that is a wire pusher. Do you have the little pusher? The back is like a T, just to show it. So this is basically what, like how a lollipop will be. And basically that helps you to push the wire while you're backing out your flexible rimmer. This is my fault because I didn't ask them to have it ready, and I just thought that now it would be a good moment to show it. But basically we rim there, and then we will advance the sheet again over the wire. Same move of doing your 90-degree turn, removing your wire with the inner part of the sheet, and then you get your next balloon. Yeah, 8 or 9. 8. So these ones in the spectrum, usually I put as a straight balloon. I don't get the conical shape. Usually these ones are 8 or 9 millimeters in thickness. If you can I tried to get the thicker one. Basically, I advanced this over, and again, I didn't do this before, but like basically you pull this sheath again as we did in the other ones, and then basically you inflate the balloon again. X-ray there. You see the balloon there is starting to inflate. X-ray again. You can see how the spiral gets wider. X-ray. X-ray. Then I got resistance there. Then I'm just going to stop there, and then we will have this one also for the curing process. So can you can pull back with the so basically the first balloon that we put cured already. So if we can do a close-up, you're going to see here a marker that shows scissors. You have the heavy scissors. And that's where they're going to make your cut. Before you do any cutting, you're basically going to undo this blue cap. And as you pull the inner wire, this wire will come easily if the balloon has cured in the appropriate way. You remove the entirety of the part and you basically confirm that no pieces are left behind. Once you pull that out, you take your heavy scissor and then you cut the balloon at the location where the scissor is marked. And then you have this device that helps you to cut the balloon. There are two thicknesses. This is the thicker or bigger one that goes to the bigger balloons. Basically make it go in there. You touch the end of the bone, and what you're going to do is start to spin it, kind of like to eat the edges of the connection to the balloon. And after you do that, you have a back slab hammer device that you're going to secure on this. You squeeze it, and then you pull it, and then the balloon is turned. This is sometimes there is a little, you have a rongeur. There is a little bit of the plastic that may stay out still. You can basically just take that with a rongeur. Being careful of not traumatizing the skin or the subcutaneous tissues. And basically you check with your finger and then confirm that there is no balloon behind. Sometimes I like to leave a little bit of the balloon prominent, just to also feel by myself that the balloon has cured completely. And then what I do is I just take that little piece of balloon as well after we're done. Then you feel your edges and they're smooth, and that's how you cut the device. You can come to an AP if you want to with the X-ray. Just somewhere in here. Then get an X-ray there, and then you see the balloon at the level of the bone, and you basically do the same with all the balloons. And you see there our T going all the way anteriorly to the acetabulum and both balloons out of the joint. Then you just have to irrigate your wounds, close them. I like to use monocryl or something that I don't have to remove, especially for this incision in the ischium because it causes symptoms. And that's how you sterilize the pelvis. So we're just going to go over a final slide that will be our conclusion. So basically, I find this a very versatile instrument to manage metastatic disease in the pelvis. because it follows the contour of the pelvis, because it follows that shape, allows you to use implants that are longer. It allows you to rebar the entirety of the pelvis, getting a device that gets thicker and wider in areas where the bone is at its weakest. A key point is that you can use this in non-contained defects, which I think is a plus compared to other techniques, such as cannulated screws and cement packing, which are limited basically to the use of contained defects. You don't need to remove this device if you have to do any other surgical procedure. You can do total hips on this. You can add screws. You can add plates. You always can do the conversion from minimal invasive surgery to a bigger surgery. That's something that you have to always be prepared. If incisions are small, this doesn't mean this is a small surgery. You need to be prepared for bleeding. You need to be prepared to open if necessary. And lastly, the advantage is like the surgical time is shorter and is reduced. So we're going to wrap it up there. And